This is Group 9's presentation of Rwanda. Rwanda is in the sub-Saharan Africa. According to the World Bank Group, the population of Rwanda in 2018 was 12,301,939. The gross national income was in 2018 was 780 US dollars, which makes it a low-income country. In Rwanda, there are both local health centers and district hospitals. Services at the local health centers include child growth monitoring, vaccinations, chronic care management, and services at district hospitals include surgical emergencies, specialty appointments, and family planning services. As far as a standardized health insurance policy, the premium rates are the same for all incomes. This means that some low-income individuals are unable to afford the premium as they are not income dependent. Geographical accessibility, such as distance and/or travel time, are significant barriers to care. According to numerous studies, distance to health centers correlates negatively with healthcare access and with lower health outcomes. Since the 1994 genocide, Rwanda has made significant improvements in social and economic reform, especially highlighting the health sector. In this slide, policy, regulation, and financing of the Rwanda healthcare system will be touched on. The Ministry of Health holds responsibility for policy and priority setting, financial management, budget execution, and audits. The Ministry of Health, Rwanda Biomedical Center, and National Referral Hospital make up the central level of the pyramidal structure. This level elaborates policies and strategies, ensure monitoring and evaluation, capacity building, and resource mobilization, and helps provide administrative, technical, and logistical support. The implementation and the organization, or Mutelis, is ran by community representatives and local healthcare providers. The scheme is run as autonomous organization and is managed by its members, helping people to share the risk of having to pay in full for treatment at village and district levels. Healthcare in Rwanda is funded several different ways. Since the implementation of Mutelis, citizens pay 1,000 Rwandan francs annually, which is equal to about $2. This funds about 50% of the scheme. Other funding comes from other NGOs, multilateral agencies, and the government of Rwanda. For example, the Global Fund to Fight AIDS, Tuberculosis, and Malaria helps fund the Mutela insurance scheme. The President's Emergency Fund for AIDS is another fund that helps provide antiretroviral treatment. In 2013-2014, 57% of total health budget was financed by external donors. Providers are paid by Mutelis directly or through monthly rate on a fee-for-service basis or performance-based payments. Rwanda has adopted healthcare facility quality assurance approaches or standards towards accreditation as a priority to improve healthcare quality and safety. The health sector monitoring and evaluation system regularly measures the sector's performance and how it contributes to achievement of the goals set. Performance-based financing is an example of a system which ensures proper monitoring and reporting by providing performance incentives, and reimbursement is affected as well. With the implementation of the community-based health scheme in Rwanda, 90% of the population is covered. Rwandan indigenous medicine stresses the flow of bodily fluids. A healthy body is considered by enough bodily flows, not excessive or inadequate. Bodily fluids that play an impact in their health are saliva, blood, semen, urine, and breast milk. Poisoning is viewed as a major cause of illness. Spells or poisoning follow the flow and blockage belief. Unhealthy or afflicted bodies are described by disorders in flow states, such as blockage of breath in the lungs. There is no theoretical difference made between physical poisoning and enchantment. They practice Western and indigenous forms of medicine. There are hospitals and health centers that have been built by Christian churches, but they continue to seek care from indigenous healers that combine herbal medicine and spiritual cares. Traditional medicines have been known to fight infection and diseases where Western medicine has failed. However, not all of these herbal remedies or rituals can fight against certain diseases such as HIV, AIDS, malaria, and tuberculosis, which coincidentally are some of the most prevalent in Rwanda. Advances in health have been a result of simple practices such as bed nets to prevent malaria, improvements in nutrition and contraception, immunization, and community-based treatment for malaria, pneumonia, and diarrhea. However, there are still serious barriers to health. 4.5% of houses have running water, duration of exclusive breastfeeding is insufficient, 20% of infants older than 6 months has diarrhea in any given 2-week period, and only 29% receive oral rehydration salts. 44% of children have stunted growth, and needs for contraceptions are high. HIV, AIDS, malaria, tuberculosis, hepatitis B and C, typhoid, breast cancer remain prevalent. The leading causes of death are malaria, HIV, AIDS, lower respiratory infection, diarrheal diseases, and protein energy malnutrition. Due to advancements in the health system in Rwanda, they have reached near universal health insurance coverage. Although not absent, immunizations have decreased the incidence of cervical cancer almost completely. In the last 10 years, cases of HIV, tuberculosis, and malaria have dropped by nearly 80%. If these advances continue, these diseases can soon be eliminated. The rapid scale of antiretroviral therapy has shown great success and can be contributed to these results. Because there is still such an emphasis on non-Western medicine, it is necessary to educate the population on when it is appropriate to seek help from indigenous healers and when it is necessary to seek medical help. Delays in diagnosis and treatment can be detrimental, so ensuring that the community knows when to seek medical assistance can result in better outcomes. It is difficult to retain and recruit trained personnel in rural areas of Rwanda, and inconsistencies in staffing can lead to reduced compliance on safety measures such as hand hygiene. This means that there is a need for healthcare workers that are invested in their communities to ensure a continuation of care and collaboration. This can be done by providing formal education for people in the community or provide advanced education to those with degrees, such as nurses. Not only do NGOs offer financial support of the healthcare system, they also provide resources and healthcare workers to serve in underserved areas. This can be limited though, as some only provide short-term assistance or only aid in crisis situations. Delays in treatment are caused by lack of knowledge, cultural practices, age, fear of social stigma, and socioeconomic factors. Utilization of the local community nurses as well as the healthcare workers provided by NGOs to educate the population on when to seek medical help and that there are better outcomes when they do seek help early would lead to earlier diagnosis and treatment. Rural nurses tend to live and practice more in underserved rural areas than physicians. So training and licensing them as advanced practice nurses or nurse practitioners could bring a much needed resource to underserved communities. The Human Resources for Health program, in collaboration with the Clinton Health Access Initiative, have formed a 7-year partnership with the Rwandan government and 25 academic medical centers and schools in the United States to develop education, collaboration, and educational development programs for physicians, nurses, and other healthcare professions. This is a long-term project with many goals that must be reached before it can be implemented, so it will require a lot of resources, but will be a great opportunity for the people of Rwanda.